Now to our main discussion. As we join the global community to raise awareness and promote action against cancer in Nigeria, there is a need for urgent and collective attention in the fight against cancer. Joining me in the studio is a consultant, clinical and radiation oncologist at the Nigeria Sovereign Investment Authority, Luth Cancer Center, Dr. Chidebere Agbakwuru. We'll be discussing the challenges, opportunities and ways forward in dealing with Nigeria's cancer crisis. It's good to have you here, Doc.
Thank you. Good evening, Nigeria.
All right, so, it said that every cancer diagnosis has a unique, personalized experience, and all of that. So let's talk about the theme of this year's commemoration, United by Unique. What is its significance and how does it relate to personalized care? And how do you think our healthcare system can actually, adapt to it?
Okay, thank you for that. So we're coming off the 3-year theme, the previous 3-year theme, which was closing the care gap. So now we're on to Unite by Unique. So what it means is that we're doing a concerted effort, but looking at each person's peculiarities. So it's a people-centered approach that is looking at the needs of each person. Because the reality is that each person who has a diagnosis has a different story. Some people have a lot of background issues that make their situation even worse than somebody with the same diagnosis. So essentially, in a nutshell, it's looking at each person's peculiarities and making sure that the system works for them.
All right, making sure the system works for them. And in Nigeria, we seem to have a rise in the number of cases, despite the enlightenment, that we keep hearing on days like this. Yeah. What do you think is responsible for that rise in cases?
Okay, I think we usually like to say it's a change in our lifestyle, which is one of the things that is very true. But of course, it's also an increase in our capacity to diagnose. So we have better capacity to diagnose and to find these things early, find them at whatever stage, you find them, and you realize that when you find them and when our lifestyle changes are detrimental, it kind of like leads to an increase in the diagnosis. So essentially, our capacity to diagnose and detect is better now. And of course, we're adopting a lot of lifestyle changes that manifest with onset of these diseases.
Now, when you talk about improved diagnosis, then I'm thinking about, it doesn't mean that this actually existed back then, but we probably didn't just have the needed technology to diagnose, as quickly and as early as possible.
Oh, yes. Probably later on, when a couple of questions that lean towards this come up, I'll talk about, the whole arc of finding out, being conscious of your health status, yeah, presenting to a doctor, and the doctor also demonstrating competence lead to you getting diagnosed and getting treated. But essentially, it's because, we didn't know so much about it back then because health education is really poor in Nigeria. And, depending on the economic predisposing situation in the country, what their priorities are. And if someone is having issues with actually putting together food on the table, you kind of find out that the list of their priorities is finding out why they have this nagging stomach pain that hasn't gone away for 4 months. So people usually had these things, but we didn't really know what it was. You probably might have said, grandma died in the 80s, she had a back pain that wasn't going away, and suddenly she passed. But if you look back and you do a postmortem, or you look at the statistics, the probability that she probably had multiple myeloma is on the map there somewhere. So we need to look at these things with a scientific lens and not just rule off anything as probably some attack from the village or something even more ridiculous than that.
When people talk about village people, right?
Yeah, yeah.
Okay, I'm talking about some of the statistics that we actually have. As at 2022, we had about 127,763 new cases. That's quite massive.
Well, I think that's an underestimation because if you look at how this data is sourced, if you go to the very bottom of that page, you'll see that none of the references were made from Nigerian data. These were actually projections and predictions and postulations. So I can tell you that that's a huge underestimation because there are a lot of these cases that don't even report at healthcare centers. There are a lot of them that are managed by charlatans. There are a lot of them that are managed by religious leaders and stuff. So what you find is that the numbers we have, yes, they're bad, but I assure you they're probably at least 1.5% more than that.
Now, that's quite, worrisome. And we seem to have more females, coming down or being diagnosed with cancer. Based on the statistics from Global Can now, we have about 48,000 males, and the females about 79,000. That's almost a double.
Okay, so it depends on if you're talking about across both genders separately or looking at the genders distinctly. So both genders, putting them together in terms of incidence, you have breast cancer, it's at the very top. You have prostate cancer, then you have cervix, uteri. But if you separate them across the genders, you know, in the men, what you now have is prostate at the very top, you now have colorectal cancer, and you now have liver cancers. In the women, you have breast cancers, you have cervical cancers, and you have colorectal cancers. So yes, a large part of the demographic is actually over the female gender, correct?
All right, and you know, before now, when you hear about cancer, the thought was always, that's like, you know, a road, like a path leading to, you know, the end. But we've also had doctors say that, no, it's not a death sentence. How do you assure people that being diagnosed with cancer is no death sentence?
Okay, this question comes up every time about this whole death sentence things, and people throw their arms up in the air when they hear about a cancer diagnosis. And, you know, there's this feeling of hopelessness and doom and gloom that comes over. But, you know, I think you can draw a straight line from that to the fact that we pay for healthcare out of pocket. So that is where I think the doom and gloom stems from, because the cost of it actually is what crushes you. It doesn't necessarily mean that you can't get a cure. It's just that, you know, it's quite expensive and it's tasking. So in some countries, people don't really take a cancer diagnosis as a death sentence anymore. I was in Accra over the weekend and I saw that there are stage 4 lung cancers now that are being cured. And it's ridiculous to even fathom, if you think about it some couple of years ago, that you would cure stage 4 cancer. But these people are doing research and they're prioritizing their health care. And you see that they're getting and reaping the bounty of it. All
right. And of course, the world over, you realize that more than half, about half of the population actually lacks access to quality healthcare. How do we, in Nigeria, bringing it home to Nigeria now, how do we ensure, you know, equitable distribution of the available resources and ensure that everyone actually does have access to good healthcare? Okay,
your statistic is very correct. You know, about 50% of the world actually have access to very good healthcare. So there are so many components. It's multi-pronged. It's not a problem you can point at one thing and say, this is what it is. So I was telling you I was going to come back to this arc later. So the first thing you need to do is to make people aware of these things. So health education, being well-oriented about your body is very important. So when you now notice something that's off in your body, because you are aware, you've been told before that having a lump in your neck is not a normal thing. It's not a boil. So the next thing you do after that is to go to a doctor. So when you go to a doctor, because I think that in the 90s there was this ad that used to say, if symptoms persist after 3 days, go see your doctor. So that's literally telling you that if this is there for 3 days, you have to go see your doctor. So when you go see your doctor now, it might be a primary care provider at the local hospital next to you. So the doctor also now bears the burden of responsibility. You've done your best. You've gone to see the doctor. The doctor bears the burden of responsibility for clinical discernment. I'm not putting the burden of diagnosis on him, but clinical discernment tells you if this is something you can handle, if this is something you have an idea about, or if it's something you should move along the chain. So clinical discernment says, oh, this person has had this ulcer for 6 weeks, I've given triple therapy, and they're not getting better. You move the person over to a tertiary institution. Now, the tertiary institution sees this patient, and they see several like that, so they know what to do. So the next thing now for them to do is to solve the diagnostic dilemma. Make a diagnosis. So when they make a diagnosis, they now give the patient the treatment options. And this is where I always say the problem starts. Because diagnosis is becoming less and less of a problem in Nigeria. It's actually the treatment. So the doctor tells you you're going to need immunotherapy for a couple of months. And, you know, you now get the falling away. The patient now leaves the arc. They've done so well. They've moved from awareness. They've gone to diagnosis. They've gone to discernment and all that. And when it gets to treatment, they fall off.
Why do they fall off?
It's because we're paying out of pocket for the most part, and the treatment is expensive.
All right. We'll see if we can, you know, put a figure to it, and then, of course, also address some myth, because we're beginning to hear people say all sorts on social media, but that will be after this break. So let's take this quick break. When we come back, the conversation continues. Please stay with us. We're talking cancer. Today is World Cancer Day, and we're looking at, you know, how we can really help the situation considering the rise in a cancer burden. in Nigeria and, of course, across the world. And my guest is Dr. Chidebere Agbakwuru. Yes, there's a trending video online. A doctor says, as a man, earlier you spoke about 3 most common, cancers: prostate, cervical, and breast. So he says, as a man, you must ejaculate 21 times. Is it in a day or in a week or so for you not to have prostate cancer? How true or correct is that statement?
I saw the video and I just chuckled to myself. It's one of the things that I think is a symptom of the disease. And the disease is that, we should have better regulation of things like that in the public space. That is what you call classical misinformation, because it's not evidence-based. Now, while you have freedom of speech, as a healthcare practitioner, you owe it to the people who are listening to you to actually tell them information that is evidence-based. I'm not going to come join issues with the guy because, he's a respectable person, right? But I'll let the regulatory agencies earn their wages and figure out what to do with that, because that's not evidence-based. You can't go to any international conference and say that you'll be laughed and shoved out of the room. So probably the regulatory agencies will look into that and see if that kind of information should be making its way around the airwaves. It's very dangerous information to put out.
All right, but you know that sometimes we also hear about, there are certain doctors who seem to have cures to some of these ailments and diseases. Talk about Ebola, talk about even cancer or even HIV, but they say, somehow they just would not allow them get to the point of proving, their findings over the years.
Okay, so as for that, I think that's a completely different thing.
Okay.
If you're talking about therapeutic efforts made by healthcare professionals in trying to develop cures, trying to develop panaceas for certain conditions, it's different from making unfounded claims. Unfounded claims as large as the fact that lack of ejaculation leads to prostate cancer. Look at the studies. Okay, first of all, the first question I would ask if I were on the panel interviewing the guy, I would ask if you've subjected this to scientific rigor. Have you documented this? Have you published anything? Have you actually had it peer-reviewed? If he has, excellent. I'm all for new information, but I don't know what the answer to that is, so that's a different thing. But as for looking at new cures, now it's very difficult to speak about that, because the reality is that there is a very, very strong resistance between orthodox and non-orthodox approach to medicine. And I think each side has something to learn from the other side. It's largely possible that there are off-label medications that could help with malignancies. And I think they should be studied. I really think we should have these clinical trials and find out and see. So for example, if you wanted to design a clinical trial like that, you have to give people, it's probably because people haven't been in these situations. These people need to explore every safe avenue for a cure. If you designed a clinical trial, you would say, people who have stage 4 malignancies that can't get any other orthodox care, will subject them to these medications, which we are familiar with, which we know that don't kill people. They're really safe. And you look at the other arm, we don't give them anything. You look at that and see what happens after a couple of months. So I think we should look at that. We shouldn't just shove it off and laugh it off. You can't laugh at something you don't understand. You haven't studied it and you want to laugh about it. I'd be a fool if I say those things don't work, because I haven't tested them. So I think we should look into that and see what happens.
But do you think ejaculation could actually help to prevent the risk, or lack of ejaculation could, predispose one the more to some forms of cancer?
No, I don't think so. No, I don't think so. Not at all. So if you're asking me indirectly about the risk factors for prostate cancer, the risk factor for prostate cancer, which is the cancer that was being spoken about by the gentleman, correct?
Yes.
So the risk factor for prostate cancer, first of all, will be increasing age. Then your descent, which will be your race, African American, Caribbean, they tend to have these more. And there's also the third one, which is there's a familial cluster of prostate cancer cases within families. So previously, there used to be this conversation about diet and how it used to affect people and bring them down with prostate cancer. But that's been declassified largely. So I'm talking about established risk factors being declassified now. So you can't bring up things that are largely, they don't even qualify as myths because they're ridiculous. If you look at the demographic of people who have prostate cancer, in the last 5 years, I don't think I've seen any clergyman who has prostate cancer. And this is the demographic you're talking about, people who don't have, when I say clergymen, I mean Catholic clergymen who don't have sex, right? That would be a nice way to look at this and study this. So looking at it from something as superficial as that, you find out that it's unfounded and it's ridiculous.
So does it then mean that, okay, because, you know, you brought up an angle now about these men who are celibate, you know, as it were. So does it then mean that, is it about having multiple partners or having a dedicated partner, you know, that could predispose one? Because I'm just trying to, you know, draw the lines between these points you're making now.
Okay, so established risk factors
of
prostate cancer are the 3 I gave you. Every other thing else is speculation. Okay. And remember that studies are continually ongoing, but there's nothing currently in the literature that draws a straight line from sexual deprivation, lack of sexual interaction, celibacy, to having prostate cancer. That's not true.
All right. So we've spoken about prostate cancer, and of course that's among men, right?
Yeah.
Okay, let's talk about breast cancer. You know, it's largely you talk about women, you know, being diagnosed, you know, breast cancer. But I hear also that men are themselves also, you know, they stand a risk, especially because why?
1% of breast cancers happen in men.
1%.
1%, yes, it happens in men, and it was previously poorly understood, but we've started seeing, you know, a cluster of cases now. I think in the past 3 years at our center, we did a study on the number of male breast cancer cases we had, and over the past 4 years, we had about, I think it was 20-something cases of male breast cancer. So that's a long time, but that's still a lot of cases. So it's something that awareness will take care of. That's why I said at the very beginning of the circuit is awareness. If you don't know, you would think it's absolutely ridiculous that this lump in your breast is breast cancer. But if you know, you will go have it checked out by a doctor who also knows that this could be male breast cancer and who escalates it to somebody who knows exactly what to do.
All right. And do you know that there's something about our society and discrimination? Sometimes, at least I've heard of a case where somebody had breast cancer. She was aware. Not only did she see the lump, you know, it was beginning to, you know, have some funny looks, sight and all that. But then she kept quiet about it and warned her family not to inform anybody about it. So how do you deal with such situations?
So I think it brings us back to the theme about the unique aspect, so united by unique. So unique means that you look at the social determinants of health. So in an area like Nigeria, where we are largely, you know, in the lower socioeconomic rungs, and we have these cultural drawbacks that shame people. How can you shame someone for something that isn't their fault? So we are shaming culture largely. They shame people. They say, oh, it's probably something they did when they were young. It's their sins catching up with them. It's their village people. So that's one of the things we do at the center where I work, the NSI Youth Cancer Center. We bring these conversations to the fore. We have these conversations. We go into the public, into the community. We advocate, and we speak to the government also to make policy that would prevent all these kind of things from happening. Discrimination is one of them. Misinformation is something else. So we're really working on trying to let the stench out of the room so that everyone can actually speak about what means something to them.
Tell us about cervical cancer.
Okay, so cervical cancer is one of the low-hanging fruits. And when I say low-hanging fruits, if you look at the disparity between our statistics and other countries' statistics, what you will see is that they have a lot of lung cancer prevalence and incidence, but you hardly see cervical cancer. It's in the lower rungs there. If you look at cervical cancer in probably statistics coming from Europe, you would probably see that in terms of incidence or prevalence, it's about 7th. But I just gave you the statistics for female gender malignancies, and cervical cancer is number 2. So it's one of the cancers that can be prevented. And by prevention, I mean, let me give you the definition of prevention. Prevention is having all the information and doing all you can, minimizing your chances to a bare minimum. Doesn't necessarily mean you eliminate completely, but you reduce it to a bare minimum such that without some freak occurrence happening, you're not going to come down with this. So cervical cancer can be screened for, can be vaccinated for, and it can be detected at the pre-invasive stage where it hasn't become a malignancy. So essentially a very low-hanging fruit for us.
All right. Let's talk, briefly about the NSIA, Luth, where you work, about the most equipped, cancer care center in West Africa. And we understand you've treated about 13,000 cases since 2019.
Correct.
So that's just like a period of 6 years now.
Yeah, a lot of work has gone on there, and you know, the NSI Youth Cancer Center. Do you want to ask a question?
Yes, I wanted to ask about, you know, what this means for, you know, cancer care in Nigeria, and how can we improve on this?
Okay, so NSI Youth Cancer Center was a godsend. I said this when I was here last year, that you know, it's a collaboration between the NSIA, the acronym you just mentioned, Nigerian Sovereign Investment Authority, and the Lagos University Teaching Hospital in 2019. And there was a huge investment by the NSIA into Luth to upgrade and reinforce on what we had already at Luth. So since 2019 till date, upward of 13,500 patients have been treated. So it offers comprehensive cancer care. So comprehensive cancer care stands on a tripod. It's very important to understand that you cannot be called a comprehensive cancer care center if you don't prevent, treat, and do research, because each one feeds into each one, and no table can stand on two legs. So we have the facilities in terms of the latest radiotherapy techniques, IMRT, VMAT, electron therapy, to treat a variety of malignancies, such that previously our people had to go all the way to countries like India and Turkey and wait in line and spend their life savings to get treatments. But now they can get these treatments in Nigeria here. So that saves a lot of burden to the families and, of course, to everyone who is affected in particular. So in our center, not only do we have these facilities, but now we're delving into subspecialties to make sure that we have subspecialty programs. We have a gynecology oncology program. We have a pediatric radiation oncology program. We have a head and neck malignancy program. And also, importantly, we have a preventive health program, which is to prevent it from happening. For example, if we see one of your relatives who has breast cancer and you come with them to the clinic, we let you know that we have this program that you can also pass through to identify your risk factors and to reduce your risk, essentially.
All right.
So that's what we try to do.
But cost is of essence, too. In 15 seconds, how do you think we can make this affordable?
I think you leave that to the policymakers, because I think you're venturing on the political here. I think it's important for us to prioritize. If you care about your people, if you really care about your people and you care about what happens to them, you would prioritize that. So that comes to the legislators, that comes to the decision makers. And I also have to give some credit where it's due. I read in the papers a week ago, Minister of Health talking about how we're opening 6 new cancer centers by May. That's largely commendable. But we also have to establish ways for people to afford these things. It's all well and good to have these facilities, but you should be able to afford the facilities. And I'll leave that to the legislators to figure out. So
accessibility, one leg, affordability, another leg. Consultant clinical and radiation oncologist at the Nigeria Sovereign Investment Authority Luth Cancer Center, Dr. Chidiebere Agbakwuru. Thank you very much for your time on the program.
Thank you so much for having me.